Booty bumping. Keystring? Welcome to Journal Club.
Hey everybody, welcome back to Magic Monday here on the Overrun, the Monday afternoon Journal Club. We have a really interesting paper today coming out of the Journal of Emergency Medicine. This came out earlier this year. This is a case study, and this is the Breaking Bad portion of Monday afternoon Journal Club. We are going to talk about the joy of methamphetamine.
Let them cook.
Let them come. So this is a case study that comes out of California for a way of ingesting methamphetamine that was previously unknown to Danny and I. This is rectal administration of methamphetamine, which is also known as plugging, booty bumping, keystring, or butt whacking. So if we're not whacking, so if anyone's not heard those terms, here's a new term. So Danny, let's go ahead and talk about methamphetamine.
Yeah, methamphetamine is something that's been out west for quite a while. It is now starting to show up in the East Coast. It is a sympathetic stimulant. You can get really high on it, and it can cause a lot of physiological problems, kind of like over-revving your engine, if you think about it. Not a good thing. So this was the case of a 28-year-old man presented to the ED. He had no medical history, and he had never taken methamphetamine before. And someone told him it would be better if he put it up his butt, which he in fact did. They found a quarter-sized piece.
That's an argument I've been trying to make for years. I've never gotten that kind of success, so I gotta give him credit for that.
I mean, you admire the hustle. So they found a piece estimated about 500 milligrams to 1,000 milligrams of methamphetamine. Not sure the purity or whatever it was. What they did notice was that almost much faster than normal, he started to become symptomatic. He started to become diaphoretic, tachycardic, had a sense of impending doom. All of the things when you have some kind of sympathomimetic toxidrome, like a methamphetamine or a cocaine or a stimulant like that. So they ended up having to treat him, and it was something novel that they hadn't seen before. So thankfully they published it.
And so talking about this route of administration, it's easy to joke and laugh about things, but there is actual, pharmacological science behind it. One of the advantages of rectal administration of any medication is that it bypasses the liver, so it bypasses your first pass metabolism. Right. It's not necessarily similar to IV administration, so I don't want the viewers to get that confused, but PR or per rectum drugs can actually absorb very quickly, which is probably the reason why you see it, especially in kids. And you see it a lot in patients who have seizure disorders. Again, you can give it pretty easily. The medication is usually administered pretty quickly. They also have really good absorption in the rectum. So how does methamphetamine work? Now, anyone who's been watching the show or has seen me present anything knows that I love me some old medicine stories, because almost every illegal medicine that we have now was once a great medicine in medicine. Heroin was sold as a hero drug. Cocaine was sold as a stimulant to get you up and going in the morning. And amphetamine is in fact still used today pharmacologically. It's usually known as Adderall. So there are uses for methamphetamine, which is why it's listed as a Schedule II stimulant under the Controlled Substances Act. One of the things I think is fun about methamphetamine was that it was used as a nasal decongestant when it was synthesized in the 1900s.
Wow.
Which, yes. And also... It sure does. But also medications like Sudafed, pseudoephedrine have similar effects, and that's where the nasal decongestant effect comes in. It was used extensively, and this is coming from the NIH, it was used extensively in World War II, the Korean War, and the Vietnam War. And then after those wars, it was heavily used among motorcycle gangs, and that's where you hear the name crank come from. But essentially the way that this drug works is it promotes the release of monoamine neurotransmitters, things like dopamine, serotonin, and norepinephrine, and it blocks the reuptake of dopamine, similar to the way that cocaine does. So essentially what happens is you're taking this medicine and all of the things in your body that keep you awake are just circulating to continue to keep you awake. there's a lot of things that, like, symptoms that you can see. Your patients might have cardiovascular insults, certain CNS insults, but one of the bigger things that you'll see is they tend to be over agitated, and you'll also see a lot of bruxism, which is the grinding of the teeth. Now, because of all this and because of the way the drug works,
also huddling in bathrooms, solving the world problems.
yeah, exactly. Just red string conspiracies. Can we talk about Pepe Sylvia? I've been waiting all day to talk to you about Pepe Sylvia. So when you get to these patients, and again, one of the side effects of a drug like methamphetamine can be paranoia. So if you're, we're having fun here, but there is a reality where if you're showing up to a patient and you're wearing a uniform, patients who are high on methamphetamine might not be super stoked to see you. Yeah. And one of the problems that we have here is our treatment availability is very, very limited. In EMS, pretty much the only thing that we have available to treat methamphetamine overdoses are benzodiazepines. And there's only so much that you can give them before they actually start, decompensating. And, there's another argument where, like, maybe you can give ketamine to these patients too. But so, Danny, go into this paper a little bit and let's talk about what actually happened once this patient got all these benzos on board.
So, long story short, we'll post the link to the paper. This patient had peripheral IV access started. They started Ringer's lactate to hydrate and to kind of almost also stimulate metabolism. They can be fluid underloaded. Rhabdomyolysis is a potential problem here, and you can see increases in like CPK and some other markers. So hydration is going to be important with these patients. Benzos is really your first line thing, and if you're in the field, lorazepam, midazolam, Valium, if you're still carrying it, these are frontline drugs, because the idea is we want to calm them down, reduce the agitation, reduce the muscle activity, and make them more calm so that they can kind of just like let this kind of wear off. There's no reversal agent here. It's about just giving them time and keeping them in a calm, quiet place where they can kind of get over this. It appears that in the case study, they were giving benzodiazepines, at which point we don't know why, but it could be from a lot of different factors. They did notice that there was a decrease in level of consciousness. GCS dropped to about 7. At that point, they decided to do an RSI and intubate the patient, which was done successfully. Kept him on a ventilator. About 12 hours later, he woke up enough to self-extubate, and still showing signs of intoxication, but at 24 hours, he was basically discharged with no sequela. Probably a very lucky person, because these things can make you do really wild things. You have a distinct possibility of myocardial damage, of kidney injury. Anytime you're doing something like this, muscle injury, and all of those things have potential degrees of badness for the body as a whole. So just an interesting thing. And the thing that I noticed about it was the rectal administration. You're going to see these people. What I learned from this, the clinical pearl, was you're going to see effects a lot faster than if they were just taking it in maybe another route. So be aware of this. This might be something that you're going to see in your area. If you do, definitely, talking these people down, keeping things quiet. Try not to have 6 people talking to them at once because they're hyperstimulated already. Select one person to kind of talk to them. Get some IV access if you carry it in your system and it's available. Definitely IV fluids, and but again, benzodiazepines. I probably, in this case, I would go more with lorazepam, being fat soluble, has a little bit longer effect than midazolam or Valium. But again, that's up to your medical director and whatever your protocols are.
And one of the things that I also noticed about this, which I thought was interesting, is looking at the way the patient presented here, right? So the patient declined a rectal examination. That doesn't surprise me one bit. But it does show the initial vital signs. It has a heart rate of 146 and a blood pressure of 138/68. So something to consider too is this patient has a shock index. And this isn't someone who's losing volume. This is just someone whose heart is beating so fast that they're actually in a physiologic shock state. So this is someone who, again, fluid administration is going to be important. This isn't someone who needs whole blood, right? But it is someone who is going to need some kind of fluid support to try and reduce their preload a bit. They also noticed the patient was tachypnic rather, and he had a temperature of 99.3. Again, these drugs make you hypersympathetic. So, you would expect them to be somewhat febrile because, again, their muscles are working overtime. Another important thing to note in here was they talk about the actual RSI procedure. After they gave this patient a bunch of lorazepam, then they gave him ringers, and then, again, they gave him more lorazepam about a half hour afterward. They mentioned in here that they didn't give oral activated charcoal, which makes sense because the toxidrome is a secondary to administration rectally. But after they gave all of these benzos, the patient's GCS dropped down to 7, which doesn't really surprise me. Again, they've been given benzos. But something that's important here is they did the finger stick glucose is 103, and they wanted to protect this patient's airway, so they did an RSI with 20 of etomidate and 100 of rocuronium. This is an important thing to mention because I think when we talk about RSI, using succinylcholine in this patient wouldn't be necessarily the best drug to use. This patient, while using methamphetamine can give you a long-term effect of rhabdomyolysis, right now with this patient, because they're so tachycardic and because we've blocked all these receptors, the muscles are working overtime. So in this situation, giving a drug like succinylcholine might actually exacerbate their condition because you might actually cause an enhanced potassium dump, which is going to cause more problems down the stream. What I think is fun in this conversation when they get into the discussion, we present a case of severe methamphetamine poisoning after intentional rectal administration. I hope that there are no cases where there was an unintentional rectal administration of methamphetamine. But again, it is usually smoked or injected, and there's various different ways that patients can get this into their system. So this is a very quick kind of case report. This isn't the way that we typically do our journal clubs. Usually we want to go over a paper and talk about how it affects things, clinically or professionally. In the summertime, it at least feels, and I'm not presenting any data with this, but certainly people are outside more. We do tend to see more overdoses and conditions like that in the spring and the summer when it's nice out. And this is certainly a situation I think that people can find themselves in where you have someone who's hypersympathetic for whatever reason. And this isn't a judgment about, people that take methamphetamine, but also understand that there's a lot of drugs out there that have similar actions to methamphetamine. So I mentioned Adderall earlier. Certainly medications like Vyvanse will have similar effects. So you can have people who take all these amphetamines or amphetamine derivatives as normal prescribed medication that can put them into these states. So if I have someone who, like Vyvanse is a good example. If I have someone who they really feel like they need to be hyper focused that day, they might take, let's say for the sake of argument, 2 or 3 doses of their Vyvanse or of their Adderall. And now you have someone who's hypersympathetic because they took their prescribed medication. Now, I'm not saying that they're taking it rectally to try and get a high, but clinically, when you go out into the field, and especially you don't see it so much now, but the end of May, beginning of June, when you have people who are about to take their final exams, that's when I think you would find this a lot more often than you would necessarily over the summer, where people are just kind of, having whatever fun, doing whatever they can. And then this is how they decided to get off. I think if you're looking for someone who might have had a methamphetamine overdose in the field, they're going to present kind of shocky, but they're going to present shocky and agitated because they are. Right. It's a hyperstimulant type of thing. And, imagine the way that you might feel if you've had too many coffees or too many energy drinks where you're just kind of really hyped up. That's a condition that these patients are in. So I think the treatment was appropriate with this patient. I think that they gave him benzos as best they could. And then once the benzos, worked the way that they're supposed to, then the patient was RSI'd. It is interesting in the paper, they mentioned the patient self-extubated himself after about 12 hours, which also doesn't surprise me. I imagine waking up, being sedated and intubated in the ICU is not the best way to wake up. But I think the treatment was appropriate in this. And I think the case is interesting because the administration is just different than what we would normally see.
Definitely.
So for this journal club, again, this is a rectal methamphetamine overdose, which again, there's no therapeutic dose of methamphetamine. So any rectal dose of methamphetamine is an overdose. But I know what you guys think. Have you had anyone who's overdosed on methamphetamine rectally, or have you had anyone who's overdosed on methamphetamine I guess through inhalation or through injection, please let us know. Thank you for watching the Journal Club. Hit subscribe on that button right there. Listen to all the Journal Clubs and all the things that we do. And for the Overrun Monday Afternoon Journal Club, I'm Ed Bowder. He's Dan Schwester, and we will talk to you all next week.